Welcome to the deep dive. Today, we're getting into something really critical, tension pneumothorax.
Yeah, definitely one you need to know inside out.
Exactly. Think of this as your kind of high-yield revision session. We want to pull out the absolute key points you need for this condition, which, well, it can be life-threatening. We've basically boiled down our notes to give you that clear, concise picture. Perfect if you're prepping for exams or just want that solid clinical grasp.
Absolutely. And it's not just about knowing the textbook definition, is it? It's about being ready to act.
Because time is critical here.
Massively.
Yeah.
With tension pneumothorax, speed and decisive action make all the difference. So yeah, let's dive in.
Okay, so let's start right at the beginning. In simple terms, what is a tension pneumothorax?
Okay, so essentially you've got air building up in the pleural space. That's the gap between the lung and the chest wall.
Right.
But here's the dangerous bit, it's under tension. This trapped air forces the lung on that side to collapse, and the pressure inside the chest just skyrockets.
Okay, skyrockets. What's the mechanism? How does that pressure keep building? It sounds relentless.
It is. The absolute key thing to get is the one-way valve effect.
One-way valve?
Yeah, think of it like this.
Yeah.
Air gets in during inhalation, maybe through a tear in the lung or chest wall.
Wow.
But when the person exhales, the flap closes and the air can't get out.
Ah, okay. So it's like a door that only swings inward.
Exactly. So with every single breath, more air gets sucked in, gets trapped, and that pressure just builds and builds.
That sounds incredibly dangerous. What are the immediate threats? What does that pressure do?
Yeah, it's a true emergency.
Right.
This rising pressure causes a whole cascade of bad effects. First, it squashes the lung on that side, the ipsilateral lung.
Collapses it.
Completely collapses it, which
Yeah.
leads straight to low oxygen levels, hypoxia. But doesn't stop there.
Okay.
The pressure gets so high it actually pushes the structures in the middle of your chest.
The mediastinum?
Exactly, the mediastinum heart, big blood vessels, it shoves them over towards the other, healthy lung. And that shift kinks and compresses the big veins, returning blood to the heart. So you get impaired venous return, less blood gets back to the heart, less blood gets pumped out.
Which can lead to?
Traumatic cardiac arrest. It's that serious. So yeah, severe difficulty breathing, that severe respiratory distress, that's a massive red flag.
Got it. So this one-way valve,
Yeah.
how does that situation actually start? What are the common causes?
Well, the fundamental problem is always that valve letting air in but not out. But what creates that valve? Trauma is a big one.
Like a car crash.
Yeah, or like a penetrating injury, maybe a stabbing, even just a broken rib puncturing the lung can sometimes do it.
Okay.
But it's not always trauma. Some medical procedures carry a risk.
Oh, like what?
Being on a ventilator, positive pressure ventilation can sometimes force air out into that space. Inserting a central line if the needle accidentally nicks the lung.
Right, iatrogenic causes.
Exactly.
Yeah.
And also, people with underlying lung diseases like COPD or emphysema, their lungs are already a bit fragile.
Makes sense.
And sometimes, even a simple spontaneous pneumothorax, where a lung collapses suddenly without trauma, can unfortunately develop into a tension situation.
Okay. Are there specific things that make someone more likely to get this? Risk factors.
Yeah, definitely. A history of lung disease is a big one. We mentioned emphysema. That's a classic example.
Right.
Anyone on mechanical ventilation, particularly with high pressures.
Right.
Obviously, a history of chest trauma or those invasive procedures we talked about.
Central lines, lung biopsies.
Things like that, yeah. And also, if someone's had any kind of pneumothorax before, simple or otherwise, they're generally at a higher risk of it happening again and potentially progressing to tension.
Right. Okay, so air gets trapped, pressure builds. Can you walk us through that step-by-step physiological nightmare again, the pathophysiology?
Sure. So step one, air gets into the pleural space through some kind of defect, but it can't get out. That one-way valve.
Check.
Step two, intrathoracic pressure on that side starts to climb rapidly. Step three, that rising pressure squeezes the lung on the affected side, compresses it, collapses it. So no gas exchange happening there.
Leading to the hypoxia.
Exactly. Step four, as pressure keeps building, it pushes the mediastinum, the heart, trachea, great vessels, across to the contralateral side, the opposite side.
The mediastinalshift.
That's the one. Step five, this shift kinks and compresses the vena cava, reducing venous, return the blood flow back to the heart.
Less blood in.
Means less blood out. Cardiac output drops. That's your cardiovascular compromise, your hypotension, your shock state.
And if that's not fixed?
Respiratory failure, cardiovascular collapse, cardiac arrest. The domino effect.
A very fast, very dangerous domino effect. Okay. This sounds like it could maybe look like other serious things. What else should be on the differential diagnosis list?
That's a crucial point.
Yeah.
You need to think broadly initially. Obviously, a simple pneumothorax is on the list, air in the space,
Yeah.
but without that dangerous tension buildup. Pulmonary embolism, PE. That can cause sudden shortness of breath, chest pain, tachycardia. Looks similar sometimes.
Right.
A severe asthma attack, again, respiratory distress, wheezing maybe, but the underlying mechanism is different.
Bronchoconstriction, not trapped air.
Precisely. Then you've got things like ARDS, acute respiratory distress syndrome, though, that often develops a bit differently, and even cardiac tamponade.
Fluid around the heart, squeezing it.
Yeah, pericardial effusion causing tamponade can also impair venous return and cause shock, distended neck veins.
Yeah, some overlapping signs.
So lots to consider. How do you tell them apart, especially when things are critical?
Well, clinical assessment is king here. You're looking for that combination of signs. Severe respiratory distress, PLAOS, unilateral decreased breath sounds, PLAOS sound. Maybe hyperresonance on that side, PLAOS hypotension, PLOHS is descended neck veins.
And potentially tracheal deviation, though, that's late.
That's often a very late pre-arrest sign, yeah. So you rely on the earlier cluster.
Yeah.
Imaging like a chest x-ray can help. It'll show the collapsed lung, the shifted mediastinum.
But, and this is the critical bit, if you strongly suspect tension pneumothorax based on the clinical picture, the patient is crashing, gasping, hypotensive, then you absolutely do not wait for an x-ray.
Treat first.
Treat first, needle decompression immediately. The x-ray can confirm it later or rule it out if you were wrong, but you can't afford that delay.
Got it. How common is this, actually? Do we see it often?
Thankfully, no. In the grand scheme of things, it's relatively uncommon in the general population.
Okay.
You see it more associated with major trauma, or sometimes as that complication of medical procedures we mentioned. Specific UK-wide data is a bit patchy, actually.
Now the takeaway is?
The takeaway is, regardless of frequency, it is a critical, time-sensitive, life-threatening emergency whenever it does happen.
Right. Okay, let's nail down those clinical features then. What are we looking for at the bedside? You mentioned a few. Maybe that Manat could help.
Yeah, we could try one. How about pressure?
Pressure. Okay, let's break that down. P.
Pleuritic chest pain, sudden, sharp pain, often worse on breathing. Respiratory distress, severe shortness of breath, rapid breathing, gasping. Tachypnoea.
E.
Emphysema, well, subcutaneous emphysema sometimes, that crackling under the skin. But maybe more reliably, extreme hyperresonance on percussion over the affected side, like tapping on a drum.
Okay.
Sip to the trachea again, often late, away from the affected side. Or maybe signs of shock, like hypotension.
Tech at S.
Let's go with sound decreased or completely absent breath sounds on the affected side. That's a big one.
U.
Unequal chest expansion. The affected side isn't moving as much.
Second R.
Raised JVP, jugular venous pressure. Those neck veins are distended because the blood can't get back to the heart easily.
And the final E.
Extremely low blood pressure or evidence of cardiovascular collapse. Tachycardia is almost always there too. Cyanosis, that bluish tinge can happen. Oh, and pulsus paradoxus, where the pulse feels weaker when they breathe in.
Okay, that pressure mnemonic covers a lot. Pleuritic pain, respiratory distress, emphysema hyperresonance, shift shock, sounds decreased, unequal expansion, raised JVP, extremely low BP collapse, plus tachycardia, cyanosis, pulsus paradoxus. That's helpful.
Yeah, it captures the main things you'd look for in that crashing patient.
So we see these signs, we suspect tension. Investigations, you said none are needed before treatment.
Absolutely. Critical point. 0 investigations needed to initiate emergency treatment if the clinical suspicion is high. Do not delay.
Right.
Now, if the patient stabilizes a bit after you've intervened, or the picture wasn't initially clear and you have time, a chest x-ray is the key investigation.
What will it show?
You'll see the edge of the collapsed lung pulled away from the chest wall.
Yeah.
You'll see the mediastinum, the heart shadow, the trachea pushed over to the opposite side. You might also see the diaphragm on the affected side pushed downwards, flattened.
Okay, what about CT?
CT gives amazing detail, obviously, but it's absolutely not for the initial diagnosis in a suspected tension pneumothorax. That's for stable patients, or later on to look for underlying causes, perhaps. Diagnosis of tension is clinical, first and foremost.
Clinical. Got it. So high suspicion, what is the immediate management? What do we do?
Needle decompression.
Mm-hmm.
That's the immediate life-saving step.
How and where?
You take a large bore cannula, like a 14 or 16 gauge, and you insert it into the second intercostal space, mid-clavicular line, on the affected side. just above the third rib, to avoid the neurovascular bundle.
Second space, mid-clavicular line.
That's the traditional spot. Some guidelines now also suggest the fourth or fifth intercostal space, slightly anterior to the mid-axillary line, as maybe being better, especially in larger patients where the chest wall is thicker anteriorly. But second space is still widely taught and used.
And what should happen?
You should hear, and sometimes feel, a sudden rush or hiss of air escaping. That's the trapped pressure being released. It's diagnostic and therapeutic.
Okay, that hiss confirms it.
Pretty much. That immediate release of pressure should hopefully start to improve their hemodynamics, their oxygenation.
So needle decompression is the first step. What comes next? Is that the definitive fix?
No, needle decompression is a temporizing measure. It relieves the immediate tension, but that hole can block or air can reaccumulate. The definitive treatment is usually a formal chest drain or tube thoracostomy.
Right, inserting a proper chest tube.
Exactly. That's typically placed in the safe triangle bordered by the latissimus dorsi muscle posteriorly, pectoralis major anteriorly, and the nipple line or fifth intercostal space inferiorly.
Okay.
That tube is then connected to an underwater seal drain system which allows air to bubble out but not get back in, letting the lung re-expand.
And how long does that stay in?
Usually until the air leak stops, no more bubbling in the drain, and a repeat x-ray shows the lung is fully re-expanded. That might be a few days.
What if the air leak doesn't stop after, say, a few days?
If there's a persistent air leak for, maybe 2 to 4 days, sometimes longer, depending on the situation, then surgical intervention might be needed. A thoracic surgeon might need to go in and repair the defect in the lung that's causing the leak. Sometimes they do pleurodesis too, to make the lung stick to the chest wall.
Okay. And what about supportive care alongside this?
So, absolutely vital. High-flow oxygen is crucial, aiming for SATs above 96% ideally. Pain relief, adequate analgesia is important because chest drains can be uncomfortable, and pain can hinder breathing and coughing.
Makes sense.
And in trauma cases especially, you might consider prophylactic antibiotics to reduce the risk of infection around the chest drain site, like empyema.
Right. And just to reiterate, if you're in a situation with no immediate x-ray access.
Clinical suspicion high. Needle decompression, don't wait.
Okay, crystal clear. What's the outlook usually? The prognosis.
If it's recognized and treated promptly, the prognosis is generally very good. People can recover fully.
That's reassuring.
It is. But the flip side is that delays are catastrophic. Delay in diagnosis or treatment dramatically increases the risk of, the worst outcomes. Cardiac arrest, severe brain injury from hypoxia, death.
So time is everything.
Time is absolutely everything. Early intervention saves lives and massively reduces the risk of long-term problems. Prompt recognition, prompt action that equals a good prognosis.
And what are those major complications we're trying to avoid by acting fast?
Well, the big immediate ones are cardiac arrest and respiratory failure. That's what kills people acutely.
Right.
Then there's the severe hypoxia, which can cause brain damage or damage to other organs if prolonged. The tension mediastinal shift itself puts huge strain on the cardiovascular system, and potentially you could get irreversible damage to the collapsed lung if it stays down for too long, though usually it re-expands well.
And sadly, a fatal outcome is possible.
It is, yes. In rare cases, especially if treatment is significantly delayed or missed, it can absolutely be fatal, which just hammers home again how vital rapid intervention is.
Okay, so wrapping this up. Tension pneumothorax, a true surgical emergency. Air trapped by a one-way valve, pressure builds, lung collapses, mediastinum shifts, cardiovascular collapse threatens.
That's the core sequence.
Key signs remember pressure, pleuritic pain, respiratory distress, emphysema hyperresonance, shift shock, sounds decreased, unequal expansion, raised JVP, extremely low BP.
Good recap. And remember tachycardia, cyanosis too.
And the management mantra. If you suspect it clinically, do not wait for an x-ray. Immediate needle decompression followed by a formal chest drain.
Perfect. That immediate decompression is the life-saving step. Everything else follows from that. Keep that one-way valve mechanism in mind and the domino effect it causes.
Excellent. Well, if you want to really test your understanding of tension pneumothorax and loads of other essential MSRA topics, definitely head over to passthemsra.com.
Yeah, it's a fantastic resource. Loads of practice questions, really detailed explanations to help you nail this stuff.
And also check out freemsra.com, another great place for free resources and tools to help you prepare.
Definitely worth looking at both. Keep pushing with your revision. You're building knowledge that really matters.
Absolutely. Thanks for joining us for this deep dive, and we'll catch you on the next one.